Hi, everyone. It's Brenda from Lympha Press here, and we are so glad that you could join us for a really interesting presentation by one of our favorite people, Dr. Caroline Fife. The topic is pediatric lymphedema cases, bandaging, and imaging review. We're hopeful that Missy Baylor is going to be joining us as well. But before we get started, hope you're having a great day, everybody. Please know that this is being recorded. We are going to provide the link to everybody who has registered after the fact. We also want you to put your questions in the Q&A and feel free to let us know you are here in chat. We'd love to know who's out in our audience today. And without further ado, because I know your time is valuable and so is our esteemed guest, Dr. Caroline Fife is the co-editor of today's Wound Clinic magazine. Before we even went live, I had 10 other ideas for other webinars that I want to do with her. She received her bachelor's and her master's from Texas A&M University College of Medicine. She has provided a specialty-specific electronic medical record system to wound and hyperbaric centers across the United States. When you think wounds, you think Dr. Caroline Fife. And yet today, she's bringing us something a little bit different. And it's so important to have knowledge about the pediatric lymphedema patient and how to care for them. Dr. Fife, what led you to come up with this idea for this presentation today?
You know, Brenda, I always feel like such a fraud when we're talking about lymphedema. I have to back up for just a second and tell you how this all started. I was running a wound center at the University of Texas at the Texas Medical Center. I'd been running a wound center for almost 8 years. Women started to call me in 1997-ish saying they had lymphedema. I would say, do you have a wound? They would say no, and I'd say, I can't help you, click. Hopefully I was not quite that rude, but it happened repeatedly. Wow. And eventually I went to my chairman and said, you know, these women are calling and I can't get rid of them. And I don't really know anything about this, but there's this meeting I could go to and there's a book. So I went to the National Lymphedema Network meeting, I think in 1997 or 1998. And and they convinced me that, you know, there was probably enough patients I should hire a therapist. Missy was one of our first therapists, but the hospital didn't think it was going to be useful. The department didn't think it was important. And there was no investment, no advertising. And at the end of a year, we had 6 MLD therapists working for us. And the lymphedema side of our clinic was bigger than the wound center. So it was all based on mostly initially women who would network and say, hey, there was no other place to be treated in Houston in 1998. So then what came as a natural outgrowth, because Texas Children's is right across the street, they started sending us little kids, in some cases infants. And fortunately, my background is family medicine, so I didn't panic when somebody brought me a baby. Some of my other colleagues who were internists would run out the door as fast as possible when there was a baby. But I didn't know anything about this. And part of my big caveat is I'm not a pediatrician. I'm not a geneticist. I'm a family practice doctor who was just pressed into service to see these children because nobody else knew what to do. So I'm going to give a sort of high level view of this, just trying to give people some ideas of things to look for so that you can identify patients who may need further follow-up from genetics or pediatrics or some other expert, not me. I'm like many people in wound care, my one gift is pattern recognition. And I think that's probably true for lots of therapists and people in the wound care space. We kind of fall into this because we're good at recognizing patterns. And so, you know, you don't have to know what somebody has, you just need to know that it's not normal and that it's different than what you're used to and that you should ask someone. Like, that's all you really need to know is this is not what I normally see. That'll get you started.
Well, I am excited to get started with this presentation. I'm going to disappear and give you the stage. And thank you, Dr. Fife, for being with us today. I'm all ears.
Thank you so much for inviting me, Brenda. So I've already given you a caveat, which is, so while I'd love to be clever enough to answer questions about genetics and inheritance patterns, I have the most basic understanding that a family practice doc can have. I really just want to focus today on some things that might still be true and might not be true based on what we learned from imaging, and some big picture things about what you should be looking for. The book says that primary lymphedema is a very rare disease that affects about 1 in 100,000 individuals. That means there ought to be about 23 of those people in Houston. But if I had more than that in a clinic, I'm thinking that it's more common than we think. It's just getting missed. And I believe that all of you know that. Pediatric lymphedema ended up representing about 10% of our practice. And that's just a little snapshot of the reality. But wow, that's more than you would think, right? You hang out a shingle, you think you're going to see cancer and adults, and then all of a sudden teenagers and sometimes even small children start to trickle in, and you're not really sure what to do about that. Lower extremity is more common in children, but it can be absolutely anywhere, any part of the body, the face, the genitals, anywhere. We saw children as young as 6 months, but many had been identified at birth. And of course, the dramatic presentations are probably going to get sent to genetics and figured out before they happen into a clinic. Now, our big picture understanding, and this is what all the books say, is that remember, the word congenital means it's present at birth. Everything that's congenital, meaning present at birth, doesn't have to be genetic. But most of the lymphedema syndromes have a genetic link. Some of those genetic things are sex linked, and some of them are autosomal linked. Autosomal chromosomes are the ones that handle everything else besides sex. So I'm going to point out some that are sex linked and some that aren't. The other thing to remember about things that are genetic is that they can either be a dominant or a recessive pattern. And everybody, of course, has a general sense of what that means. If you and your husband have brown eyes and you have a blue-eyed child, that you probably each had a recessive for blue eyes, although eye color is a bad example because it's way more complicated than that. But at any rate, the big picture understanding has been there's the congenital cases that are identified usually within 2 years of birth. The one we've been calling lymphedema precox, which is usually around puberty, and the lymphedema tarda that begins after about age 30. So even though they may be genetic, we think they're genetic, although maybe not the way you think, they aren't always obvious at birth. So this classification is kind of true. I'm going to talk about what we've learned from imaging that might put some nuance on that. But the sort of big picture philosophy to understand is this lymphedema precox, this one that is the most common type of primary lymphedema. It's an autosomal dominant, so both males and females can be affected. Usually we're identifying it at puberty. And in most cases, the affected person has a parent with obvious lymphedema problems. So if you see it, if a teenager comes into your clinic, you're going to want, there's Missy, you're going to want to have the parents take the shoes off if you have access to both parents. And the sad thing is you may only get this figured out after the fact. This is a case Missy and I saw. A very healthy teenager. No, I don't think you saw this one, Missy. A healthy teenager had undergone pediatric surgery for something that was a minor foot problem 6 months before. The stitches had been taken out, and then a few weeks later, a small opening along the incision starts to drain what the mother described as egg yolk colored fluid. And when they would press on this, the fluid would squirt out. And I don't have to tell that there's a lot of undermining in that pocket. Totally healthy kid in every other way. And I don't have to tell you what we found when we took her shoes off. She has a stemmer sign. She had really obvious primary lymphedema, obvious to us, not obvious to the person who did her surgery. And the mom is not affected. So I didn't have a chance to look at the dad, but I'm just pointing out the fact that she knew that she had a problem with the swelling occasionally of this foot. It was actually chronic. She was kind of used to it. Nobody really identified it as an issue. They didn't warn the surgeon. And so it wasn't identified in time. And sadly, the surgeon didn't notice that her foot was swollen, or I think the surgery could have been reconsidered. Now, the Milroy's disease, which is the type 1 that affects infants, is supposed to be very rare. It is also an autosomal dominant, which means you could see boys and girls. The lymphedema is usually identified shortly after birth. It's usually unilateral lower extremity, but it can be anywhere. The boys may have a hydrocele fluid in the scrotum. I'll show you a picture of that in just a second. And one of the tells are the little up slanting toenails and deep creases in the toes. But I'm just showing you the picture of this adorable baby who's really quite content. Any therapist looking at this would take a look at the bottoms of those feet and be able to see which foot it is, right? You can tell it's a weird little crease on the bottom of that baby's right foot, which is on our left, that looks different than the other foot. And of course, it's always hard to tell those up slanting toenails and tiny little baby toenails, but the toenails are just growing straight up on that foot. So I wanted to spend a few minutes talking about what we learned from imaging. And then let me see if I start to dig in too much to your time. I'm just going to try to get off as quick as I can, and we can talk about some of these other things another time. But I wanted to show you a little bit of a taste of what we're learning with near infrared imaging, and then we'll get one of the infrared imaging teams on to talk more detail about this. But this is a tiny microdose of indocyanine green dye, which would pop under the skin, sort of like a bee sting. And then the camera was actually picking this up in real time. This is a still photograph, but you can actually see the lymphangions pumping. You can see the fluid moving. And this is what a normal image looks like after you do a tiny little injection on the top of the feet and the ankles. Those are the lymphatics that we're actually imaging in real time. This is a normal picture. I just wanted to give you a normal sense before I show you this really interesting family. So on the left there, E is the unaffected dad whose lymphatics look great, totally normal. And then on the right there is the mom, and the mom, whose images are in F and G, has a really interesting story in that the left foot had been diagnosed with lymphedema tarda when she was past her 30th year. And you can see those lymphatics are kind of swollen and that you can't see the distinct channels. They're tortuous. It's a little hard to see the distinct channels. But she'd had an injury on the right and had developed what was being called acquired or secondary lymphedema on the right leg. And when the dye goes in, you can see it just sort of spills out everywhere. And there's this diffuse green glow, and you don't actually see any individual channels. I've provided the link to the paper at the bottom there. And purpose of this isn't really to talk about the specific genetic problem that was found, but they had two daughters. And one daughter had unilateral lymphedema precox. It presented as a teenager. Look at the dye injection in her foot. Again, this, dye just sort of oozes out in a lump like you spill your coffee. You can't see any distinct lymphatic channels. But her younger sister had bilateral congenital lymphedema that had been diagnosed at birth. And she has really no evidence of distinct lymphatic vessels at all in either one of her lower extremity limbs. So she presents as a child, as an infant, and the sister as a teenager, the mother in her 30s, and then the mother has an injury and ends up with what was diagnosed as secondary lymphedema. So the point of this is, first of all, the imaging can show you when people don't seem to have functioning lymphatics. But second of all, the concepts that we have for precox and tarda and even for secondary lymphedema are probably not gonna read the same in the textbooks in 10 years, because now that we can look at these patients, we have a sense of really it's a lot more nuanced. And Missy and I found this in some of the studies we were doing, that women who had breast cancer related lymphedema, the unaffected side, that is the one where they didn't have the cancer, hadn't had radiation, hadn't had surgery, the so-called normal appearing side, the lymphatics weren't okay. In other words, the breast cancer may have just triggered the development of lymphedema as a result of the fact that their lymphatic system was not normal to begin with. So I'm just sort of giving you the sense that here you've got a dad who's okay, a mom who's not. The two daughters are both affected. So again, an autosomal, even though both the girls, the children were girls, it's a dominant autosomal trait, then they're both going to be affected regardless of whether they're boys or girls. And this particular thing is a genetic disorder that affects the growth of the lymphatic system, not one of the genetic syndromes that we clearly understand. It was a new newly identified syndromes. So now I just want to spend a few minutes just to point out a few patients or syndromes. They may come to you as an adult, but in fact, they've had a problem, they're congenital and just not diagnosed before. And a relatively common one is the triple X syndrome. They have 3 copies of the X chromosome. Obviously, this is only girls that it affects. Only about, and this blows my mind, if we're talking 1 in 1,000 females, that is super common. That means we probably know somebody who has this. The presentation can be variable, like they fit into the society, they don't look abnormal. This little girl is absolutely precious. She's on one of the, I got this off Google, she's on a website to raise awareness for trisomy X, and I love her little sign, keep calm, it's only an extra chromosome. But in some cases, they can have, they're usually tall, that's about the only thing that I can point out. But in some cases, they may come to adulthood and show up in your clinic, perhaps after an injury, perhaps related to cancer. And in fact, they are genetically predisposed to have problems. Turner syndrome doesn't get missed very often because those girls have some unusual features. The webbed neck is one of them. Although since the presentation of any of these can be extreme to minor, it can be quite difficult to give a recipe for how to find them. But Turner syndrome girls tend to be short. They may not have puberty at all because they have their ovaries don't develop, so they tend not to have breast development. And if they aren't given growth hormones, they tend to be very short. But lymphedema is one of the syndromes, features of the syndrome that can be associated, that we just don't, even when you look up, in fact, if you go to look on the National Organization of Rare Diseases, NORD, they will often forget to include lymphedema on the list of the features of the syndrome. And yet everybody knows that lymphedema can be a feature. And I just threw this in here because it's fascinating. I've only ever seen one of these. They're the, so you know how to pronounce this word, it's distichiasis. I had to really practice that to get it right. It is rare, but it's autosomal dominant. We don't know how frequent it is. They have lymphedema in both legs that begins around puberty. And they have this second row of eyelashes. If you can see, I put little arrows there. The eyelashes kind of grow in the wrong direction. And so they end up with a lot of eye irritation and problems with their eyes. So if you see a lymphedema patient who's got kind of chronic eye problems, just remember there's this super rare problem that often gets missed. Noonan is not something people would likely miss because they have very pronounced facial anomalies. They're cute little kids with low set ears and wide set eyes. Their little ears are rotated back. They can sort of have droopy eyelids. A lot of these kids have congenital heart disease, a webbed neck, and short stature, but I don't think anybody would miss this because you would know from looking at the child that there was a syndrome involved somehow. And again, it's interesting the frequency with which they describe everything in the book except the fact that they can have lymphedema. And sometimes it can be really very pronounced and disfiguring. The one that Missy and I have seen more than once, and in one case, I diagnosed this in an adult who was 80 years old and it had been missed her whole life, is Klippel-Trenaunay-Weber syndrome. They can be Klippel-Trenaunay or Klippel-Trenaunay-Weber, depending on whether there's bone involvement. We don't really understand very much about how the genetics work in this, but the thing to notice is unusual birthmarks. They have these things that are called port wine stains. And the reason is that they have both lymphatic and vascular anomalies, and the vascular anomalies contribute to their profound problems with lymphedema. And these are not bruises, these are port wine stains. So just keep your eyes open when you're seeing a patient. If they have some unusual birthmarks of any kind, just in the back of your mind, you can think, you know, I just wonder if there's something that requires a little more follow-up. Because remember, we can't fix genetic problems, but some genetic syndromes can be linked to cardiac issues and other problems that people want to know about. So knowing what you have is better than not knowing what you have, even though nobody can, you know, at this point, correct your genes. So the other take-home message is that the parents are often affected. So daddy and mommy bring this little girl in. He doesn't mention that he has swollen feet, but because he's sitting there, I said, say, hey, Dad, take off your shoes. And he's got tremendously profound lymphedema that he's had all of his life. And you'd think he would bring that up when they brought the little girl in for her foot problems. And he doesn't even mention that he's got a problem. If I hadn't asked him to take his shoes off, it would have been missed. Mom had normal feet. So, just if you see a kid, then take advantage of what you can. And this is not a slide that I need to show to therapists. This is the kind of slide I show to doctors. I show this slide to doctors and say, can you figure out which foot is involved? I guarantee everybody who's watching this has already said, of course, it's her right foot. There's a lot of tells there. One is that funny little Y that they get between the big toe and the second toe. And it's obvious too, because the foot is a lot more swollen than the other side. Although the other side, I would say, is not 100% normal. It's just more obvious on one. And this is the saddest thing that we've seen. This is heartbreaking for Missy and I have really grieved over how to help these patients. The one on your right is a 17-year-old girl with genital deformities who would get, this is cellulitis. She was prone to these sudden episodes of cellulitis that would put her in the hospital. It's very hard to figure out how to help these folks. That's worth an entire separate discussion. The young man has a hydrocele. That's the reason his scrotum is a weird size and shape and enlarged. Very embarrassing problems to deal with. These kids feel ostracized. Their futures are not going to be normal. This is really a heart-rending problem to have, and we don't have good solutions for them. And it's very difficult to figure out how to put these folks in compression. Sometimes you cause ulcerations. This really requires opportunity to reach out to your colleagues and try to put your heads together. Missy and I can tell you a lot of ways that don't work. Missy has a few ways that do. And some of these pictures are old. These are not terribly common problems, but the primary lymphedema does tend to be unilateral and or at least asymmetrical. If both sides are affected, one is affected more. The leg tends to be affected. The foot tends to be affected before the leg. And then this little girl on your right is only 4 years old and she has profound swelling. And of course, as Missy's going to tell you, some of the challenges are you've got a squirming child who, doesn't even want to wear a hat when it's sunny, and you're going to try to figure out how to get them to agree to bandages. The Missy and the other therapists are stars about that. And I wanted to point this out. This little girl we followed for many years. I have a picture of her at age 12. She has 3 of her 4 extremities affected. And she would, even if we wrapped her too aggressively, she would go into heart failure. So there's a lot going on with this child. It's not simple taking care of these kids. This is her at age 12. You can see that both legs and one arm are affected. And we went on and this is when she's a littler than 12, but we could see fluid in her abdomen. This is beyond the scope of our conversation, but just be aware that these anomalies may not be limited to the lymphatics of the skin. They can have other very severe anomalies that can have a profound impact on their life expectancy as well as their quality of life. So just a few tips of things to be looking for as you're seeing these folks.
Dr. Fife, the whole time you were talking, I was glad my mic was muted because I kept saying, oh my.
I know, your heart breaks, doesn't it?
And it
especially
does.
when we have such poor treatment options for these folks. And we hope things will get better with imaging, that we can understand things better. And the one thing I will say that's kind of encouraging is that there's so much interest in genetic disorders that in some ways, if you have a genetic disorder, you're more likely to see a change in your lifetime because there's so much excitement around tackling genetic disorders. So maybe that's a little, we might make more progress in that than obesity.
If we can acknowledge and recognize the signs early and start treating these children early.
Brenda, thank you for saying what I neglected to say, because it's just like cancer treatment. The earlier you make a diagnosis and the more aggressive your early treatment is, the less severe the presentation becomes. And the little girl with Klippel Trinani who had the port wine stains, she's only, I think, 12 or 13 years old. I've forgotten how old she was. She very seriously asked me if she could have a leg amputation. That was her goal. Wow. In her mind, that would be a better life for her. And, all the children that Missy and I met they're wise beyond their years. The ones we imaging stings. I've been imaged many times, so has Missy. It's not fun. These kids are tearless. We've told them in the clinical trials, we don't think we can help you with this. We just want to understand. And little kids have said, if doing this to me can help someone else, I want to do it. Like, it is really a compelling thing to be involved with these kids and their parents. It's a great mission. It's sometimes hard to control your feelings about it, but there's tremendous courage and bravery in this community.
There really is. And, you know, Lympha Press does have solutions and offers pneumatic compression for the pediatric community. We can get into that later, but we are all ears, Missy Baylor. We are so proud and honored to have you here with us. I'm going to disappear again and take it away.
All right. Thank you very much. And, you know, Dr. Fife is always welcome to chime in on any of these slides as well. So as you have seen in those previous slides, there's a lot of unique challenges that we have. There can be some vascular anomalies. We always would like to see a child be seen by a geneticist if that's something available to them. We know it's difficult with genital lymphedema to manage those things. There's other anatomical anomalies that can present with children, like amniotic banding, lymphangiomas. They can be really difficult to fit because of their hard size, their small size. And it's challenging for the education, you know, depending on their age. And so we must consider their activity levels, their developmental levels when we're, you know, addressing all these issues. So these challenges, also traveling to therapy, getting to therapy, finding a therapist, patient education, you know, getting the garments made, offering and recommending any medical devices that are as an option, and also surgical interventions. So, you know, we reviewed our therapeutic interventions that we provide, and we have in the past used remote monitoring. We use the complete decongestive therapy, bandaging, kinesiotape, using our vendors that are really good at helping us troubleshoot for custom garments, pneumatic compression, and the surgical interventions. So with travel, you know, we have a lot of people that have to travel, you know, sometimes more than 100 miles for therapy. This presents a little bit of a challenge. And some come from other countries. So then they have a challenge of, you know, where are they going to stay and how are they going to get to therapy? So we have to be creative in how we, you know, accommodate these patients. So international, you know, sometimes they need interpreters. We have to be aware of the cultural sensitivities. And again, with the local transportations, the local hotels, sometimes they can offer discounts and free transportation to their therapy visits. Back before COVID, and obviously before, this is my pre-COVID hair that you see, we did do some internet monitoring where parents could send in the photographs and we could, you know, assess and help them in home therapy, you know, in that manner. So the parents are really our first line in the teaching process. We really need to address the parents first to teach them and educate them so that they can then transfer that information to the child. As we are working with the child, we teach them how to perform the manual lymph drainage. We'll have them practice it back on us so that we can check their technique, check their pressure. I mean, we always want to encourage the involvement of the child. You know, children as young as 3 can be taught how to do simple lymph drainage. They can also do their own bandaging, you know, depending on the level of, you know, involvement of the products that we're using. We want to use objects and stories that children can relate to, you know, storybook characters, number counting. There are techniques that we use, like I had a 2-year-old that we used to recite the 3 little pigs where the wolf would huff and puff. And so to help them engage in the diaphragmatic breathing. Some other things like pinwheels or blowing bubbles can, you know, help children assisting in learning how to engage with their diaphragm. Again, back to education, it's so important to help the parents learn as much as they can, give them the resources, the books, the websites for them to go to get accurate information. So we always will refer to the Lymphedema Network, Learn, the Pediatric Lymphedema Alliance. These are good, first sources to start with. So again, we want to start with demonstrating the MLD on the caregiver first so that they can understand the importance of the sequence, the technique, and the pressure. And then we want to get a self-care routine established for the child. So this is a picture of my Lympha that I use when I'm working with the pediatrics. So to kind of show them, little bears have, they need bandaging too sometimes. So our other tricks that we want to incorporate with children, anytime anybody that works with children know that you need a separate set of tools in your toolbox to work with them. So sometimes having the appointment during the time of day that's most conducive for them for the therapy, so they're not too active. And if they are, then you want to set up a play area where they can roam around and do their play. Sometimes you have to follow them around and do the manual lymph drainage while they're playing. Again, these are some of the things that you have to learn how to be flexible and in doing this therapy with children. Always try to have some kind of distraction, a DVD. I know as much as I hate kids on phones, these are a good distraction for small children when you're trying to do lymph drainage. Always positive reinforcement for the child and for the parents. It's really important. So bandaging, this is art into itself. We have to approach bandaging with a it's some unique challenges. So we become proficient in creative bandaging. So there are products that seem to work a little bit better with children. You always want to think about anything that can produce any kind of irritation or skin. You want to the skin. You want to use gentle fabrics to avoid any skin tears or trauma. These fabrics could include a terry cloth stockinette. I have a preference for TG Soft, which has that little thickness of the terry cloth lining on the inside. Sometimes we use soft roll gauze in lieu of short stretch bandages. You can layer these to create the compression. You still want to create this multi-layered compression of sequential pressure, same as with an adult. But with smaller children, you're going to have to adapt your supplies, maybe cut down certain things like the cast padding. You could, cut it down in size. You can use smaller gauze, like a 4 centimeter gauze, folded in half, rolled up. The other thing about the wrapping is that you don't want it to prevent them from being able to play, to move around. If you're doing toe wraps, you don't want to create any kind of splay toe deformity where it could make it harder for them to walk or crawl. And also, once they're wrapped, you want to kind of keep them from picking at it, pulling at it, all that hard work to get that on. You don't want it to come off immediately. So we may want to cover it with another stockinette or a sock or something to kind of take their mind away from the fact there's something there that they can pull or yank on. So we always want to use a lot of precaution with the bandaging for small children because you can very easily develop irritation. So this is something that really needs to be monitored frequently. We use a lot of kinesio tape with kids because they can tolerate it very well, especially if it's an area that's difficult to wrap, or with a teenager that has maybe a minimal foot and toe swelling. We can use kinesio techniques to do that. I had one small boy that we used the blue kinesio tape, and we called it Thomas the Tank Engine Blue. So, because he was really into Thomas the Tank Engine. So sometimes we would watch Thomas the Tank Engine videos while we were wrapping, and again, a little bit of distraction technique, but he loved the blue tape, and that really worked. It worked really well for him. So for custom garments, this is, again, one of the challenges You really need to find or become good at fitting. Find a fitter that is very, experience helps so that they can come in and help you with measuring for these garments that are always going to need to be custom. So the options for children, there's several. We typically would recommend that they be measured every 4 to 6 months, because as children grow, they're going to be needing a different size. Most children can tolerate a compression garment by the age of 2 to 3 years old, and we would recommend probably a class 1. It's easier to it's easier to don or to apply, and they can tolerate it. As children go older and bigger, then a class 2 may be more appropriate, which is the 20 to 30. I had in my experience a small boy that had been to another outside treatment place that put him in a 30 to 40 stocking, and it created some very painful ingrown toenails for him. So we don't recommend any higher compression on small children. He's now about 11 years old. He's found a good combination of like an open toe, not knee high with toe caps, and he switches those out with Velcro wraps. So again, one of the goals with garments is to make sure that it's not limiting them in their activities that they want to be involved in. And again, measuring every 6 months to get new garments is critical. So this is one picture of a small girl we had. We used a Bioconcept Lux Fab. This may not be available to everybody through different vendors, but it is still there. Is still out there, but did we use that lower compression for nighttime and then use the class 1 for daytime? And you can see that it really did help to control her swelling. And then we have, teenagers that are involved in sports and other activities. So we had one cheerleader, she was accepting of a TheraWrap because it looked more like an ankle athletic support. So, and then another basketball player that wore team color in her compression stuff. So some of the companies offer programs for children, like Solaris. They have an early impressions program. It offers a tribute night garment that's free for ages 0 to 4. They can get 2 per year. Ages 5 to 14, they can get a garment for $200, up to 2 per year. Always reach out to your local reps, to your local vendors. I've had Jobst offer free custom garments from age 0 to 14. Now, this is not straight across the board, so this is not set in stone. So you really need to talk to your vendor about this. But some of the custom garments to be fine with small children and for active, young children, young adults. The Confidence brand, the Elvrec Soft, and the TheraWrap all tend to work very well for these patients. You can also go through Bryland's Feet to apply online. They work with local vendors and fitters to supply garments for children. This is an example of one of our TheraWrap applications, and she was able to do this by herself. So she was very proud that she could do all this on her own. So as far as compression garment or compression pumps, there's not been a lot of research in this area, but we do know that they are effective. We do know that it can help with the pelvic congestion. We definitely do not want to make it a substitute for traditional therapy. We want to make sure that it is used in conjunction with their daily, self-care routine. That there are companies who can do custom sizes for these smaller limbs, and most children are pretty accepting of the pump. And in general, therapy in itself, most children are very accepting of it. It's usually that we have to work more with the parents in the acceptance part of what needs to be done. But for the children, most of the time, they're very accepting of what they need to do. So this is an example of, before the nap and after the nap, using the pump while they were napping. And of course, we always want to encourage them to be as self-sufficient as possible. This is I think it's really important to give them that autonomy in their self-care, and they're very capable of doing that if you give them the opportunity and you give them the tools to do that. So the complete decongestive therapy, it is just as, effective for small children as it is in adults, as you can see with this 36-month-old before and after treatment. So we do want to recommend that children are monitored over time. We always offer, I always tell parents, you're always free to, contact me if you have any questions, if something comes up. Please always reach out and ask. Like I was saying, sometimes we find this more psychologically challenging for the parents than it is for the children. And so sometimes they may need some help in adjusting to the things that may need to be done with their children. So patience is always critical in working with children and their families. So you may find that you may think you're walking into this room and you have a child as your patient, which is nothing at all like working with an adult, because with an adult you can have a conversation of, okay, this is what we're going to do, and explain what we're going to do. But with a child, it's going to be, you have a plan A, but you may find that you have to have a plan B, C, or D once you get started in working with the young children. So you have to be flexible, have some backup plans as to what you think you might want to accomplish in a session therapy session. You may have to, change tack and go with something else that day. So it is important that you do remain flexible. It's important to adhere to the principles of the complete decongestive therapy. We're always working with teaching them how to do self-manual lymph drainage. We're working with them how to learn bandaging with them and the parents or the caregivers, exercise. Well, with children, you don't have to tell them to exercise. They're all over the place anyway, most of the time. Skincare, it's very important. You want to make sure that we are, again, we're not causing any irritations to the skin. I know with some particular conditions, maybe like clipple trinani, if there's an area that's irritated, you can use possibly a silicone dressing over an area that could be potentially irritated by bandaging. And so I'm almost wrapping up here. Basically, we always want to make sure that you are very patient in the process of treating children, because it does require a lot.
I love that last slide. And I want to say that those children are very fortunate to have someone like you in their corner, taking care of them with such care, and even involving play to distract them perhaps from what's going on so that they're not afraid. And I love the point that you made too about the parents also needing to be sort of treated because of the psychological impact of their child having lymphedema. Also glad that you mentioned Bryland's Feet Foundation. And by the way, Dr. Fife, come back and join us so that we can debrief and ask some questions and get some answers. Lympha Press is one of the primary sponsors for Camp Watch Me, which is a camp for children with lymphedema and their parents. So it really supports both sides, and the kids get to experience camp like never before. My colleague, Alexa Ercolano, who works in the marketing department here at Lympha Press, has primary lymphedema, and she went as a camp counselor this past year. So
How
for the
fantastic.
first time. Wasn't that awesome?
Fantastic.
And she said, I got to go to camp. I got to
Brenda,
play.
we need to put that information in today's wound clinic so that the doctors who have these patients, they're sprinkled around everywhere, and people would be thrilled to know about these resources. And we need to get the word out where it's easy to spread.
I absolutely
it's
agree.
really important, yes, for the kids that go. One of our patients had gone to the camp, and he had a great time, and just being with other kids that have a similar, challenges, so they can, they have somebody they can relate with what they're going through.
Yeah, absolutely true.
And
we feel
that's fantastic.
We feel really fortunate that we have someone on our team who has lymphedema. It's changed the way we talk about things.
Isn't that fascinating?
I had done a marketing piece and I had written for patients suffering with lymphedema, and Alexa said, can we change that to patients living with lymphedema? Just a different
What a
perspective.
really vital perspective change.
Yeah, absolutely. So we have a question that's coming from the audience. Dr. Fife, you mentioned that writings on lymphedema may change in the coming years, especially, you used an example of a patient who had a left-sided mastectomy, but the right side, the normal side, lymphatics weren't okay. What criteria do you use to determine when it is primary or secondary lymphedema when symptoms present later in life? And isn't it obvious which one it is, especially if the patient has?
It isn't
the
always
parent
obvious.
has
Yeah.
lymphedema.
So that is such a good question, and I'm going to partially answer it. But I'll start with a story. Remember I told you I didn't know anything about lymphedema. Women made me do it. I didn't understand what a need it was. I was completely clueless. Everything I know, I learned from Missy and the other therapists and the patients. And, I read the one textbook. There are more resources now, but it's like, I basically would look at a book and walk in a room and say, hi, that is not the way you want to practice medicine, but that certainly is where I was in 1998. A few people were ahead of me, but not that many. There's always a lag between what's happening clinically and how books get presenting material. And that's getting shorter because of the ability to do online things, but philosophical changes in any specialty take time to adapt. And some of these things we're learning from imaging that not everyone has access to. So I don't think there'll really be a change philosophically until everyone has access to imaging and we're all seeing the same thing and we come together as a community to at least provide. We don't even have names for some of the things we see. We're at that looks like so-and-so and there it is again. Like we're still figuring this out. Because remember, before, the only thing we could do is wait until somebody was swollen and then everybody is the same. And I don't know any medical condition, even diabetes, that's identical from one person to the next. We now have an understanding of the nuances of that disease. But in lymphedema, it's like you're swollen, you have this thing, and then we try to categorize it based on your history. So that's the second part of the question is, all right, we take a history, and if it's birth, that's easy. And if you're a teenager, that's probably pretty easy. And if you're an adult, then all we have to do when you're an adult is decide whether it's a late presenting primary or a secondary. But the problem is their lymphedema, their lymphatics don't read the book. So I got excited working with Eva in about, I don't know, when did we start with Eva, Missy?
And when you say Eva, so everybody knows.
Eva Savick and her team. Yeah, so I would see patients, adults with profound, horrible, unilateral lymphedema that I walked in the room and thought, you've had this all your life. And the patient would say, no, I was fine until 10 years ago, a bee stung my leg and I've been like this ever since.
Wow.
I was fine until a drawer, I'm telling you real stories, a drawer fell out of the dresser, hit my leg, and I've been this way ever since. They would tell me stories that according to the book can't be true. And I would say, the book says that's not how this works. And that was also the thing we started noticing in cancer. A woman who had no nodal involvement, who didn't get radiation, who had a relatively minimal surgery and ends up with lymphedema, and everybody's running around saying, what did your surgeon do to you? And then there were women who had radical mastectomies and didn't have swelling. And we would say, this doesn't make any sense. How could somebody be screwed up when nothing seems to have been touched on their lymphatics? And the answer is all lymphatic systems are not created equal, and we don't know it until they show symptoms. And until we have imaging, we can, and get this, when we first started imaging people with primary lymphedema, we didn't know whether they have lymphatics and they didn't pump or whether they never grew them. That's kind of a big gap to have in the 20th or 21st century, right?
Wow.
Like that's pretty basic stuff. That means we're still in the Victorian era of all we can do is look at people and go, So right now we're still kind of stuck in what I would call Victorian medicine, where it's just how people look, what their history is, and that's what we do. And I'm not sure we can do better given the fact that we have a body of literature behind us that's always said this is this way. It's not that people were stupid. Everybody's done the best they could with their eyes. now that this is the same issue we had before MRI. I remember when MRI became available. I was in medical school when CT scans became available. Like, I remember PET scanning, and I remember saying, why would I want to know about the metabolism? All we ever understood was anatomy. And of course, I feel silly now, but when these new things come out, we start to be able to diagnose things we couldn't before. It changes everybody's understanding of a disease. And then we create the literature, and then we figure out, because remember, then we've got a problem with reimbursement, right? If you recharacterize a disease and you begin to understand there's preclinical problems and the insurance company will only cover if you have XXXXS, then we've got people who need treatment. We know they do, and the insurance says they don't meet criteria. So lots of things have to move forward simultaneously. So I will tell you, in answer to the questions, sorry to be so long-winded, we use their history. For the most part, it's still based on your history and age of presentation, but you will see those people, especially adults, who had minor trauma. And the thing that happened to them is impossible to relate to getting stung by a bee or bumping your arm with a baseball or any of the other minor things. The only explanation is that they had a congenital form that is something different than we understand now. But we are still calling them secondary because everything about their history is water, swine, and till.
Oh, and yet that is such an important distinction when it comes to insurance coverage too, because that primary lymphedema is really something that when it's
it has a different kind of coverage, but it's very hard to do that in a 45-year-old woman who says, I got stung by a bee. It's very difficult to say you must be a primary. And this is, before we started the event, I was telling you about things that Missy and the other therapists told me. And I would say, Missy, you're making that up. Like, you can't be right about that. Like Missy had said, Dr. Fife, we can feel lymphedema before the patient has changes in their measurements. Like, we know it's there. It's a stage 0. And I said, come on. You think you could feel that really? Well, we saw it on imaging, So
this is brilliant. Let me just stop for a minute. Missy, what does it feel like in your hands?
Well, I think it comes with the experience of that tactile touch of when you touch a person's skin, the only way I can describe it is it feels congested. It's like when you put your fingers into the skin and it doesn't want to move, then you know that there's a problem with something that's not, it's just not moving. It's just kind of stuck.
So her brain is processing some thickening, some lack of mobility, some subcutaneous edema. And the measuring tape isn't showing it, but her brain is processing stuff. And haven't we all seen, like, your kids are sick, but you can't explain why? Like, they don't have a fever. I just know they're not okay.
Okay.
There's some pattern that your brain processes by which that this is not right. But you yourself have a hard time even understanding what it is. I mean, that's part of the art. And I remember Missy and the other therapist saying, Dr. Fife, if we're doing a massage on the left arm, the right arm lymphatics start to pump faster. And I would say, you can't know that. Like, that's craziness that you think that's happening, but we saw it on imaging.
I love this topic. Go ahead.
We could also document it by volume measurements. We would take, like say we're measuring an arm against arm, and we could take measurements in the beginning, and at the end of therapy, we'd measure both arms again, and the unaffected arm had gone down also. So it's like, it's not just working that one side, we're working on the whole system.
And isn't that a powerful thing to know? Because sometimes, like with people with RSD, complex regional pain syndrome, you can't always touch them where they're swollen, but just touching other areas may begin to help them. So that's a whole different topic. But I sound like I'm very dismissive of my brilliant therapist who really did teach me all I know. But, as kind of a born skeptic, when they would say, hey, Dr. Fife, this is what we feel, it's just natural. If I believe in them and I'm saying, oh, come on, then, it's going to be imaging that's going to really tell the truth about these things, where we're going to be able to show an insurance company We're going to be able to show Medicare. We'll be able to do something about payment policy to say, this is not just that, because they're worried about abuse.
Yes.
They're worried that we're making stuff up in order to get people things they don't need.
No,
You
we
know,
want
imaging is
the science to evolve so we can get them the help
imaging is
that
the
they
only way forward. And the other thing I'll bring up, which, you know, probably I should be quiet because I'm looking at the time, but the other thing I should bring up is if you think about every major advance, think about stroke therapy. We did not have, we admitted people to the hospital, patted their hands and told their families we were sorry when they had a stroke until we had angiograms and CTs and MRIs, and we could say it was hemorrhagic, it was obstructed, we could stent that. Like treatments follow imaging. That's how things work. If you don't have imaging, you can't get treatments. Drugs might work, but if you don't have imaging, you can't prove it based on volume measurements. So,
especially since, like you said, every patient
and
is
they're not the
different and
same
unique.
thing. Some of these are pulsatile problems because we know there are drugs that make people have lymphedema, presumably by slowing down the pulsatility of their lymphatics. But if they were normal before they started taking this drug, they have to have lymphatic systems present.
Wow.
So if there are drugs that shut it off, there might be drugs that turn it on, but it's going to be very unique to the scenario because there are lots of problems that affect the lymphatics. We're going to have to know more, and the only pathway forward is imaging. So it's going to take a decade for us to even begin to rewrite those books, but it's just good for clinicians to know when a patient gives them a story that the book says isn't so, like the patient's telling us the truth. We don't understand.
Wow, that's an excellent perspective. I want to thank, by the way, we do have one more question I want to pose from our audience. Attendees, if you loved today's content, and I know you did, please, there's a link in the chat for our link tree to all Lympha Press events. We do roundtables for patients and clinicians. We do monthly webinars like this amazing content. Thank you so much, Missy and Dr. Fife. One more question from the audience. What age do you recommend starting with lymphatic scans? This attendee has a patient diagnosed in utero with Turner syndrome that I started within the ICU at 24 hours old. Oh, 24 hours old. She is now 2 months old and has seen this therapist weekly. She is an occupational therapist with a specialty in developmental pediatrics, and she's a CLT, and she is seeing her for overall developmental progression as well as her lymphedema. So what age do you recommend starting with lymphatic scans?
So the first thing we have to say is that they're still experimental in children. The FDA perspective on this is evolving, and what I said isn't exactly accurate, but it's close enough to say it's not like you can write an order and get this. The technology is still very limited because one of the things we have to do is convince a company that it's going to be useful to make these machines and send them out. So all technology waits on payment things and other stuff. But the main thing that's important about this particular patient is we don't image anybody just to image things. We image whatever it is, lymphatics, MRI, CT, X-rays. You want to do something with that information. So you've got a child who has Turner's, you know lymphedema can be part of it. If they're already swollen, you don't need imaging to tell you what to do. We do what we can. We do what we know to do. We do what Missy was describing. The imaging tends to be more valuable when you don't know what's going on and you can't explain it and you're not sure whether this is really lymphatic or venous and you're not sure what your next step is going to be. That's, I think, where imaging will be useful scientifically to help us understand the pathophysiology. But, you know, if you've got somebody symptomatic, we treat them.
Yeah. Thank you so much for that answer. And thank you for our attendee who put the question in. I'm just thinking about that little 24-month-old child and the care that child is now getting, thanks to your care out there. So I put my email address in the chat. If anybody is interested in learning more about Lympha Press, not just for pediatric lymphedema, but for any of your lymphedema, chronic venous insufficiency, wound patients, your lipedema patients, we'd be honored to help. We are extremely honored to partner with you, Dr. Fife and Missy. Your expertise has helped a lot of people today. And we need to have you back for myths debunked with imaging.
That's what we need Dr. Sevick for. And
I
Missy,
want to do
yeah.
that one and a few others, including, can you just do a little preview of your taxonomy for disorders that's forthcoming?
Yeah, this was years ago. It was published open source, but we published a paper just giving names to some of those weird skin changes that people with lymphedema have, because nobody knows what to call them. If you're going to call a doctor and say they have these lumps, like, you'd like to have better, more expert sounding terminology. And I'll send you the link to my blog, which links to the paper, but I put it on my blog just so people didn't have to go find a paper.
Awesome. We will put that, everybody who registered will get a link to the replay and any resources associated with
The
today's
taxonomy,
presentation.
you can summarize as saying, what do you call that thing?
What do you call that thing? And if everybody's using the same language, the same terminology, it's systematized, it's way more powerful. So good. Thank you from the bottom of our heart at Lympha Press. We appreciate you. And thanks everybody for tuning in.
My honor.
Today.
Thank you, Missy.
Thank
Talk to you
I love you,
soon.
Missy. Okay.
Bye. Bye, everybody. Have
Bye-bye.
a great day.